Hello everyone. Today I will be talking about dose average linear energy transfer association with local recurrence on pancreatic cancer. Uh, my presentation is divided into parts. First, I will briefly introduce the background of pancreatic cancer and carbon ion radiotherapy. Then I will explain the introduction and motivation of paper. And after that, I will review the methodology, result, discussion, and conclusion of this paper. Pancreatic cancer is difficult to treat with radiotherapy for two main reasons. One is that the pancreas is located close to several radiosensitive organs, uh, including the stomach, liver, kidney, spinal cord. And because of this anatomies, it is difficult to safely increase the physical dose. Another reason is that pancreatic tumor can be biologically resistant due to the hypoxia, which this makes local control very challenging. Carbon ion radiotherapy is attractive because it has sharp dose localization through the Bragg peak and higher biological effectiveness compared to other methodology like proton or photons. Uh, and carbon ion has high LET, which can increase RPE in tumor and might reduce the influence of hypoxia. Therefore, uh, carbon ion are promising approach for pancreatic cancer. Uh, it can show better physical dose and higher biological effect. Also, the dose average LET distribution can be controlled within the clinical target volume and the gross target volume. In standard carbon ion treatment plan, the plan is mainly evaluated using dose and RPE weighted dose as a gray RPE. However, carbon ion are biologically complex. Their biological effect depends not only in dose, but also on LET. And does average LET. Even if two regions receive the same, uh, even if two regions receive the same RPE weighted dose, the biological effect might not be exactly the same if the dose average LET distribution is different. Carbon ion radiotherapy has or can show promising local control, uh, but some patients still develop local reoccurrence, some pancreatic patients after carbon ion radiotherapy, even when they prescribe dose, even when the prescribed dose seems sufficient. LAT change along the carbon ion beam path. Because of this LET change, RBE can also change. Along the drag peak path, uh, LET change, the value of LET. Because of this change, RBE also can change value. And this means that the biological effect might not be uniform, even though uh, the weighted dose appear to be acceptable, the RBE effect is not uniform. In another word, those evaluation alone might not fully describe the biological quality uh, of the treatment plan. Those average LET profile might provide additional information that is related to the treatment outcome. However, nowadays, clinically, does average LET evaluation is still not widely used in routine treatment planning. For pancreatic cancer, this is especially very important because we need to maintain safe dose level in surrounding organs while still achieving strong biological effect inside the tumor. So does average LET distribution explain why some pancreatic tumor reoccur locally after carbon ion radiotherapy? So this paper investigate if the association between dose average linear energy transfer and local reoccurrence in pancreatic cancer patient treated with carbon ion radiotherapy. The main focus is whether the dose average LET inside the target, especially the clinical target volume, CTV, might contribute to local failure after treatment. Now, the hypothesis of this study is that low dose average LET, especially inside the CTV, contribute to local reoccurrence after carbon ion radiotherapy for pancreatic tumor. There are several challenges. First, the standard dose volume histogram evaluation may miss biological weakness inside the target, cannot show it. Dose volume histogram cannot show the biological weakness area inside the target, or volume to be more precise. The second challenge is that dose average LET is not uniform in carbon ion therapy. Dose average LET change along the path. And some tumor region might receive enough dose, but not sufficient dose average LET. And the objective of this study is to evaluate whether dose average LET distribution affect the local control in pancreatic cancer patient treated with carbon ion radiotherapy. Also identify whether low dose average LET region in the clinical target volume, CTV, are associated with local reoccurrence. And to determine whether dose average LET can be used as an additional treatment evaluation factor beyond weighted dose and physical dose. This was a institutional retrospective study from Gunma University Heavy Iron Medical Center. The study included 106 patients with inoperable pancreatic cancer treated between 2013 and 2021. All patients received carbon ion radiotherapy with prescribed dose of 55.2 gray and 12 fractions. For countering, the GTV was defined using contrast enhanced CT merged with the 4D CT. And the CT was defined by adding margin around the GTV. Then they use XUN to determine and evaluate both dose volume histogram and dose average LET's profile. Uh, the dose average LET profile parameter inside the target volume were calculated by an in-house pipeline using Python, focusing especially inside the clinical target volume. And they compared the dose average LET values with local reoccurrence using MIM, and then they find out a cutoff value, and they divided the group of these patients to lose the clinical target value and high clinical target value groups. And the a cutoff value was identified for the CTV, and it was 42.2 kV per micrometers. And the group were divided into low CTV, receiving the lower minimum dose average LET below 42.2, and high CTV, lower minimum dose average LET higher than 42.2 groups. And after that, they do the local reoccurrence, where compared between these two groups using many statistical methods, and find out the result different. Those are the methods they used. The whole statistical analysis was doing all this kind of tests. Now the result. Figure A show the probability of the patient who is still alive after treatment. At the y-axis, we can see the probability of overall survivor by percentage. And at the x-axis, we can see the time after carbon ion in months. And the n here is the number at risk of patient. They still follow them into this timeline. So the curve here decreases over time because some patients died during the follow-up. At the start, there were 106 patients. By 48 months, only 15 patients were still at risk or followed. So overall, survivor gradually decreases after carbon ion radiotherapy, showing the serious prognosis of pancreatic cancer even after treatment. In B, it shows the cumulative incidence of local reoccurrence in the y-axis and the time after carbon ion therapy by a month in the x-axis. And N is the number of patients still without local reoccurrence and under observation. There were various with time because more patients develop local reoccurrence. At the start, they were 106 patients, and by 48 months, 8 patients were still at risk. So local reoccurrence increased over time after carbon ion radiotherapy, reaching around 20% by about 2 years. So clinical outcome after carbon ion radiotherapy, the overall survivor showing gradually uh, decrease in survivor over time, and the cumulative local reoccurrence showing that local reoccurrence increase over time and reach approximately 20% at 2 years. And here they compare the local reoccurrence between patients with the low versus high minimum dose average LET in different target volume, where the pink line is GTV below 42.5 and the blue line is GTV below 42.5. Oh, sorry. The pink line is GTV LMN below 42.5. The blue line GTV LMN higher than the 42.5. Uh, and it showed the cumulative local reoccurrence according to the minimum dose average LET in the GTV, CTV, and BTV. I just want to mention, I think there is a little error here where it's supposed to be BTV number for figure C. Typing mistake here, so it is they write it CTV. Anyway, for the GTV, L lower minimum, L minimum less than 42.5 kV, it is clearly higher, which indicate that patient with lower GTV L minimum tend to have more local reoccurrence. But because B value is equal to 0.15, this was not statistically significant. So low dose average LET in the GTV might be related to reoccurrence, but the evidence was not strong enough statistically. For GTV, low minimum dose average LET less than 42.2 kV per micrometer in the CTV, it is we can see that it is clearly higher. The pink line is clearly higher, which indicate that patient with CTV lower minimum below 42.2 kV per micrometer had a higher cumulative local reoccurrence rate. And because the B value is equal to 0.030, which is in the desired range, this result is statistically significant. So the low minimum dose average LET inside the CTV was significantly associated with local reoccurrence for pancreatic cancer. Whereas the pink line in the BTV show no clear difference between the two curves. And then because the B value equal to 0.54, which is not in the desired region, not inside the desired region for the test, it was not significantly it was not statistically significant as well. So minimum dose average LET in the BTV was not strongly associated with local reoccurrence. Um, Only CTV low minimum showed a statistically significant association with local reoccurrence with a cutoff value of 42.2 kV per micrometers. This should suggest that insufficient dose average LET inside the CTV might contribute to local barrier. CTV low minimum was the strongest dose average LET related predictors of local reoccurrence. In simple word, patients who patient whose CTV had a minimum dose average LET below 42.2 kV per micrometers had significantly higher local reoccurrence after carbon ion radiotherapy. Here, they compare the local reoccurrence LR between patients with low versus high minimum dose average LET in different target volume. So they A is the local control patients and the local reoccurrence patient on the other side. They see the difference between the dose distribution and sorry, they saw the difference between dose average LET distribution inside the CTV for both local control patients and lower range patients. In figure B, uh, it shows the cumulative local reoccurrence according to the minimum dose average LET in the GTV. So the patients were shifted. I mean, we can see in the CTV volume, dose average LET have received have shifted to the right in the local control patients, which means local control patient has received higher dose average LET in the clinical target volume, whereas in the lower uh, in the local reoccurrence, patients has received lower dose average LET. This is why the curve dropped earlier here than the local control patients. For C, it shows that the more the volume increase, the lower the dose average LETs distributed. So the number of lower dose average LET are causing higher distribution with volume. In another word, the larger is the volume, the more we lose higher LET, the more we find lower dose average LET. So A, the reoccurrence patient had weaker dose average LET coverage inside the clinical target volume compared with the control patients. That's what show us. Local reoccurrence patients had weaker dose average LET inside the clinical target volume compared with controlled patients. B, uh, local reoccurrence patient had lower clinical target volume dose average LET than local controlled patients. C, large target volume are harder to cover with high dose average LET everywhere. So larger clinical target volume might have low dose average LET region, and those low dose average LET region might contribute to reoccurrence. The first discussion point is that dose alone might not be enough. Low dose average LET inside the CTV might be one reason why local reoccurrence occur after carbon ion radiotherapy. Even if the dose looks acceptable, a small low dose average LET region might be biologically weak. Tumor cells in the region might survive and later cause reoccurrence. The second point is that clinical target volume, low minimum dose average LET, was more important than the GTV low minimum or PTV low minimum. And this suggests that the clinical target volume is more relevant structures, more more relevant for those average LET evaluation. The third point is that those average LET might create biological weak region. This is important specifically in pancreatic cancer because pancreatic tumor can be radio-resistant and hypoxic. The fourth point is that larger clinical target volumes are harder to cover with high dose average LET. Tumor size and beam arrangement might affect those average LET distribution and coverage. Finally, this study suggests that those average LET should be considered in a treatment planning in the future, and the future of carbon ion therapy might need to evaluate not only the dose distribution, but also the dose average LET distribution, as it play a main important part in RPE. It can affect overall treatment, that outcome. And this study has several limitations. It was a retrospective study and it was performed in a single treatment setting. Also, the dose average LET was calculated after treatment planning, but it was not directly optimized during the planning. In addition to the cutoff value of 42.2 kV per micrometers need further validations. Finally, other biological factors such as hypoxia and tumor heterogeneity might also influence the local reoccurrence. However, the clinical implication is important. Carbon ion therapy plans may be improved, asking not only is the clinical target volume or the gross tumor volumes, the CTV or the GTV are receiving enough dose. We should also see if the entire target volume, CTV or GTV, is receiving those average LET enough as well. So we should not ask if the carbon ion therapy plans receiving only enough dose. We should definitely consider dose average LET distribution. And the local reoccurrence after carbon ion radiotherapy might not be explained by dose alone, as the maximum dose average LET inside the CTV was significantly importing and with the local reoccurrence. This suggests that even with RBE weighted dose appear to be sufficient, those average LAT region inside the CTV might act as biologically weak area where two muscle can survive. And the study also showed that the larger clinical target volumes tend to have lower minimum dose average LET, meaning that the larger target might be harder to cover biologically. Therefore, they suggest that dose average LET should be considered as an additional planning and evaluation factor in carbon ion radiotherapy. To conclude, dose average dose coverage alone does not fully explain local control. Does average LAT give extra biological information? Low clinical target L minimum was associated with higher local reoccurrence due low dose average LAT's region. Low dose average LAT region might be biologically weak area. Standard dose based evaluation might miss this week's biological region. The clinical target volume is important because it includes microscope diseases. Larger clinical target volumes tended to have lower dose average LAT coverage. The cutoff value of 42.2 kV per micrometer should be validated in the future, and the future of carbon ion radiotherapy planning might need dose average LAT evaluation or dose average LAT, or in general LAT optimization. With this, I come to an end, and I am happy to answer any of your question or hear any of your comments. Thank you very much.